بسم الله الرحمن الرحيم. محاضرة الأوستيومايلايتس. The next lecture inshallah we will cover polymyositis, yes, and then we will go some over the entirety of the module in the following lecture, one of the QA lectures. We will go through a quick revision, and then we will start the clinical vignettes. ونكمل إذا we needed more time we'll do a 9th and an 8th إذا بدكم كمان 10 كمان lectures, so you can go through clinical vignettes and scenarios. I will try to share screen for clinical scenarios. إذا كان في صورة مثلا للحالة, that is what I will share. Otherwise it will only be the vignettes which I will read, and you will have to use your own tools to come up with the solution. تمام. بسم الله الرحمن الرحيم. So osteomyelitis, as you know, and I think Dr. Musa covers a good portion of this subject, is that it's an infection of bone that leads to tissue destruction and often debility and formation of sequestra, which is a dead necrotic bone. Now, this is caused by a wide variety of bacteria, which also includes mycobacteria. هذا بنحكي where and how, but can also be caused by fungi and maybe even associated with viral infections. The management for osteomyelitis is notoriously difficult. من الأشياء اللي حكيناها بالسابق, حكينا إنه we have less penetration. أنتوا تعرفوا إنه osteocytes and osteoblasts and all the cells are covered by matrix, and penetration of medication to the bone is not always successful, and is not always as well. The pharmacodynamics is not the same as other tissues and maybe much more difficult. فكل osteomyelitis إلها طبيعتها المختلفة. So the management is tailored for each individual and each case. What are the factors that we will use for the management? أول شيء, if we know the organism, obviously that would give us which antibiotics that we can use, and then from these antibiotics try to see which ones have a good penetration to the bone. هلا which bone is involved كمان هذا بيعطيك a good indication what you need to do, and it's also linked usually to the causative organism. State of vascular supply, it is vastly important, as we just mentioned. State of the nerve function كمان helps the immune function as well, and then a good nerve function will probably aid in the treatment. Presence of foreign bodies, obviously حكينا مثلا coagulase negative staph مثلا are likely to form biofilms, and if there's a foreign body that is causing an infection, so the management will definitely have to include removal of the foreign body. A recent injury, so removal of the foreign body. شو في foreign bodies بيجي بالbones. So if you think about them, the majority of foreign bodies that are done in bones are either done in orthopedic surgery or dental surgery. يعني dentist دخل على البون وحط some sort of implant, or you have used مثلا for a joint, you replaced a joint, a knee joint or a hip joint, or there was a fracture that required the use of plates and screws, which can مثلا this fracture will not heal on its own, or the bone is too damaged. So that sometimes the surgeon will use plates and screws to stabilize the bone. What happens if مثلا انت كنت orthopedic surgeon والبليت اللي حطيته ما كان sterile, or your technique was not sterile, أو المستشفى اللي أنت فيها does not have a good record, أو مثلا team اللي تشتغل معه أو غرفة العمليات أو whatever. So you have a lapse in your aseptic technique at any level. So هذا المريض, now the plate that you introduce, the knee joint that you introduce, which is a major surgery. عادة هدول المرضى اللي بغيرهم knee joint عادة بالعادة أكبر بالعمر, knee joint, hip joint. So these foreign bodies that are now introduced, حكينا بالسابق إنه the deeper you go into the tissues, the less symptoms that you will see, and then maybe even takes weeks or days or months before actual symptoms come. So you will not have an acutely may not have acute reaction right away to indicate your surgery was clean. So these are major surgeries, and you are taking these patients, these older patients, into high stress. So if you have this lapse, what is the tailored management here would be? There would be you would have to take away the plates that you introduced or the joint, take it, تكبها بزبالة, and then you have to wait for healing. تخيل المريض هلا بجوز بدون hip أو يعني may have to be not able to use his limb or something. So ضيف على هذا, now they will have to wait for healing so their body can accept a new plate or a new joint or a new implant. So obviously that is very, very damaging. So not introducing bacteria into your this is where for foreign bodies. Recent injuries كمان يعني بنفس السياق إنه if you have recent injury, you may have to wait for healing. You may have to see the state of the nerve and the vascular function. Again, what organisms that can be introduced with this type of injury. And the status of the host and any associated comorbidities, إذا كان diabetic, إذا كان person with peripheral vascular disease, كان عنده immune suppression, المنطقة اللي إجى منها وين هو عايش, كل هاي الأمور and other past medical history are all very important. So the spectrum of osteomyelitis can range from extensive, such as metatarsal or vertebral osteomyelitis, to something that may be localized, such as a bone invasion following tooth abscess. So due to many factors that we mentioned, the syndrome is identified as a spectrum. It is مش كل osteomyelitis. It's not all the same, and it's not treated the same as we just covered. So the two major classification system, we have to use classification system in this case. إذا عندك spectrum بدك تستخدم classification عشان تحط النقاط على الحروف, so you can know where each patient can lie, so you can then direct your attention and treatment accordingly. So النوعين اللي يستخدموا the Lee and Wald-Vogel system, which has three main criteria. Is it an acute or chronic presentation? Is the spread of the infection, is it hematogenous? Has it been spread through the blood? Or contiguous? Has it been spread directly by direct spread مثلا من skin or مثلا lumen? With or without vascular compromise, as you have probably guessed, in the vascular compromise will probably be one of the main factors that will contribute to healing, or the poor prognosis if there was vascular compromise. الثاني اسمه the Tierney and Maeder system, which is used for lung bone osteomyelitis only. And it takes into account the location and the extent of the infection. So which long bone, which site in the bone, and then how far deep is the infection inside the bone, plus other factors. نرجع أنا بتعرفوا بتحمل هدول التيبلز اللي نحط كل we can build a very nice mind map with these kind of tables. So this is from the Fauci book. Microorganisms that cause osteomyelitis. What are they? بالبداية رقم 1 staph, رقم 2 also staph. So staph aureus is the most likely bacterial pathogen. It is very aggressive, it is very invasive, and often metastatic. من الأشياء اللي حكيناها عن staff إنه it likes to nest. Now if it finds a place where there's a lot of matrix وما في immune system كتير وما في حدا يحاربها, and it can grow as fast and as well as it can. So this is actually a very perfect place for a staph to grow. And this bone bone infection is probably one of the most successful places, or the most places where staph will be successful in infection. So it will be aggressive, invasive, and may have even metastatic foci with bacteremia. What does that mean? If it gains access to blood vessels, it can spread from one side to another side within the bone, or can go through bacteremia. So in this case, you may want to consider surgery early. Why? Because staph here would behave, in a manner of speaking, would behave like cancer. It would keep destroying the tissue, and the tissue will continue to become devitalized and then become even worse. So we would have to probably يعني بالخيارات الأولى إنه debridement and surgery might be a problem. عفوا a solution. Staph coagulase negatives usually associated, حكينا هذه usually associated with foreign body material, implants, by film production, which we mentioned, and then الحل هاي راح تكون obviously you will have to remove the foreign body. Streptococci, again, streptococci, the main thing is it's not a nester, it's a spreader. So this is can spread rapidly through soft tissues. So the surrounding soft tissues can help spread the streptococci. So they prefer the spread through the soft tissues. Enterobacteriaceae, E. coli, Klebsiella, and others, they have considerable variation in antibiotic susceptibility. حكينا دائما the hallmark of Enterobacteriaceae is antibiotic susceptibility. The hallmark of Streptococci, rapid spread. The hallmark of coagulase negatives, biofilm. كل اللي حكيناه so far. Staph aureus, aggressive and invasive. كل اللي حكيناه بنعاد بنفس الطريقة بطريقة مختلفة. Or with another light يعني. So increasing antibiotic resistance with overuse. Again شو حكيناها بالمحاضرة السابقة. If you want to بالdiabetic foot حكينا, if you want to cause antibiotic resistance, have suboptimal doses of antimicrobials, and this is probably a case where antimicrobials may become resistant during therapy. So عدا عن إنه we eat a lot of food which contains antibiotics. إحنا بناكل دجاج فيها antibiotics, dairy products that have antibiotics, حكينا poultry, meat has suboptimal doses of يعني very very minute doses, but they are enough to cause damage. A lot of our protein that we eat contains antibiotics. So gut bacteria get زي كأنهم أنت قاعد بتدربهم يعني you are training them on these antibiotics, and they are human grade antibiotics. بيستخدموا سيبرو, بيستخدموا كل هذا because they fatten up the livestock. So عشان هيك تشوفوا مثلا أحيانا بالمحلات مثلا poultry بيحكي لك antibiotic free, no antibiotics used, right? So if there is spread of these Enterobacteriaceae into the bone, من وين راح يجوا من skin؟ لا راح يجوا again نفس القصة. So probably through the lumen, من مثلا من ال GI tract somewhere to مثلا the spine or whatever, or مثلا إنه كان داخل المستشفى. So this is how the Enterobacteriaceae can gain access to the bone. إنه كان بالمستشفى. المستشفى فيها lapses, can have lapses in hygiene, where through patients or staff. Now these bacteria in the gut may already have antibiotic resistance, but may become resistant during therapy because you are now giving suboptimal doses of therapy. غصب عنك, you will definitely give suboptimal because you cannot increase the doses enough to cover the bacteria properly. Now Pseudomonas, again, it also has قصتين, بتحط عليها البايوفيلم وتحط عليها antibiotic resistance مع بعض تطلع معك Pseudomonas. So increasing resistance to antibiotics, frequent successor to other bacteria when initial therapy fails. True. So you are killing bacteria. You have introduced the patient into the hospital. you have not been successful in treating the patient, Pseudomonas will come into play. And then هذا حكينا may be related to contaminations because probably you have contaminated the wound or whatever, and this is how it gains access. So okay, unusual organisms. What unusual organism do you see with osteomyelitis? Anaerobic bacteria. Now again the same story. Usually mixed with anaerobic bacteria. So aerobic bacteria. So you have facultative anaerobes or aerobes that improve the place for anaerobes to come in. Maybe synergistic like we said, and survival depends on the devitalized tissue. كله هذا حكيناه عندنا أكثر من مرة. بارتنيلا هنزلي، كات سكراش ديزيز، فليز، الكات عليها فليز، تذكروا الحكي حكينا. بروسيلا ما بعرف إذا أخذتوها الفصل الماضي. But Brucella is a zoonotic illness. It's a disease that we get from animals, and it usually comes from unpasteurized milk. واحد من دكاترتنا من زملائنا بوصف بروسيلا زي كأنها multi tissue cancer because it can go everywhere and it is really hard to treat. فهي عادة تيجي من unpasteurized milk and may cause osteomyelitis, although it is unusual. Fungi, or which one do you think? Probably you'll be right if you say the yeast candida. Probably the most likely genus. It has considerable variation in susceptibility, and depending on the species, surgery may be helpful if infection is invasive. TB may involve any bone, مهمة, but vertebral osteomyelitis is very common in some countries. مهم some countries, underdeveloped countries. القصة هاي بتيجي ما بعرف ليش بحبوها كتير. اليو اس امري وهدول والبلا بيحكوا لك مثلا مريض جاي من افريقيا with back pain وبعدين بيحكي لك مثلا بحط لك يعني he will مثلا see some data انه he has osteomyelitis. So which one is the common organism, which is the probable organism? One of the things that they will say انه it's in the vertebra, back pain, osteomyelitis, بورجيك صورة مثلا CT scan whatever. Mycobacteria would be here. Mycobacteria other than TB needs special culture media, viruses, varicella and variola, although very uncommon. تمام. هلا osteomyelitis. So pathogenesis is usually due to three main routes. Hematogenous seeding. إيش يعني؟ من البلد بيمشي في some bacteria that can find a place at the ليش بتوقف بالبون؟ Because would you think that the speed of the blood going through the vessels, would it be as fast as مثلا large vessels? Definitely not. Medium vessels, definitely not. So the smaller vessels are the ones that are going to be going through the bone, and will probably be the caliber is smaller, and probably the speed at which the flow is going is probably be less than other vessels. So this would be ideal for bacteria to get off. تنزل هنا وتبلش تعيش حياتها. Contiguous spread from adjacent infected tissue. مثلا وين شفناها مثلا بالdiabetic foot. Diabetic foot كان مثلا عندك infection spreading until it reached the bone. This is contiguous spread. Traumatic or surgical inoculation. This is probably a patient هنا مثلا patient عنده مشكلة that he has hematogenous seeding and not fighting the bacteria. This is another patient who has a problem that is not healing enough for the bacteria to keep going and going and going until it gets to the bone. Trauma, المريض راح يكون كيف شفنا المريض more likely إنه to be a healthy patient, but you have had a trauma or surgery which has introduced an unusual amount of microorganisms. You have a buffer that you can deal with. مثلا إذا دخلت 50 بكتيريا وضعك تمام، 100 بكتيريا وضعك تمام. But you have a buffer. This is as much as you can handle. مثلا إذا كان في عندك trauma, you have introduced millions or thousands of bacteria. This will overwhelm your buffer, and then you will have infection, no matter how healthy that patient is. تمام. Collection of inflammatory exudates in the bone marrow leads to increased medullary and bone medulla pressure. Extension of the exudates. هذا اللي بنحكيه هنا إنه once infection happens, inflammation will ensue, and inflammatory exudates will go inside the bone marrow. Now the bone marrow is not extensible, it's not malleable زي soft tissue, it will swell. It's not malleable, so it will increase pressure inside the medulla of the bone, right? So it will keep the pressure will keep mounting and mounting until it breaks through the cortex, and then it will rupture through the periosteum. Now if periosteal rupture does occur, the blood supply will be interrupted. ليش؟ بتعرفوا blood supply بيدخل على البون through the periosteum. So once you break it, you have interrupted the blood supply. You have made the situation much worse, which leads to necrosis and then separation of the dead bone, which is the formation of the sequestrum زي ما حكى لكم أستاذنا الدكتور موسى. So the site of periosteal damage then becomes the site of new bone formation, and this is other vessels will then help in producing the involucrum. تمام. هذا اللي هلا حكيناه. So the initial site of infection increasing, it have broke through the periosteum. Now you have a subperiosteal abscess, and then you will have this is the sequestrum, the dead bone, and then you'll have new bone formation or the involucrum on top of the previous abscess. Now pus may continue to escape and may even fistula all the way to the skin, and it might happen as well. Maybe rare, but it might happen. Classification. So the Tierney-Mayer system is a functional classification based on the affected portion of the bone and physiological status of the host. There are 4 anatomical types: medullary osteomyelitis, superficial, localized, and diffuse. So there are 3 normal physiological classes: normal host with local or systemic compromise, or treatment worse than disease. هدول كلهم بحطوا مع بعض tickets. So the medullary osteomyelitis is inside the medulla of the bone. Superficial osteomyelitis is only superficial. Localized osteomyelitis, as you can see هون بجي صورتها أحسن. So it is going through both the medulla but is not breaking through the other side. Diffuse will break through the other side. So you'll have from one periosteum into the next. Etiology. So hematogenous osteomyelitis usually monomicrobial. Why? If bacteria were to break through so many barriers من السكن للأcidity of the stomach للtears للsaliva لا if it happens to break through the blood, more likely إنه one bacteria will. إذا في أحد منكم بيعرف برنامج الحسن، هذا برنامج كنا نحضره إحنا صغار، برنامج ياباني كتير مشهور، حتى كتير مشهور بإنجلند، بسموه تاكاشي's castle. فبكونوا مدخلوا مثلا 100 أو 120 واحد and they put them through a gauntlet, multiple gauntlets مثلا صعوبات مثلا so different practices and let's see if they can go through. فالمية آخر إشي بوصلوا لعند القلعة إنه if you can go through بكون مثلا 3 أو 4. This is the same thing. You have your body is like a castle with multiple defenses. So if it has to break through the core of the castle, which is the hematogenous system, is probably be monomicrobial. Contiguous osteomyelitis هذا بيكون على برا على حيط القلعة. So can be mono or polymicrobial, doesn't matter, whatever has went through at the skin site. In patients with sinuses, the superficial flora may not represent the true pathogen. تمام. So in patients that have sinuses formation of the bone, the flora on top of where the bacteria is going out, it may not be representative of the true pathogen. تمام. The most common bacteria because osteomyelitis is staph aureus and coagulase negative staph حكيناها gram negative وهذا كله حكيناها بالتيبل. ماكيوبكتيريا حكيناها with medical with limited resources. بحكي لك مثلا بيحبوا افريقيا او يحكوا لك مثلا فيتنام or something like that. Other mycobacterial species may infect حكيناها fungi, candida, coccidiosis, histoplasma and aspergillus species. All of them may cause osteomyelitis. The precipitating factor حكيناها. This can vary according to the route of infection. So a prosthetic joint, implants with the stabilizing devices اللي هم مثلا screws and plates and whatever are being used more frequently in orthopedic surgery and are associated with complex infections. هلا الجايدلاينز تبع استخدام البروستاتيك devices and stabilization devices are changing all the time. وصار في عندنا عدد اكبر من جراحين الجراحين بشكل عام وخاصة جراحين orthopedics. So there's more of them. There's probably more work to be done. There's better guidelines. There's better understanding. And حتى in some severe cases, sometimes even surgery might be done that is not even needed. So فكل هذا أكثر من factor. كل هذا زاد عدد use of prosthetic joints and stabilization devices, which changes the way that osteomyelitis has been dealt with. So now we are seeing more osteomyelitis and complex types of osteomyelitis because you are introducing unlikely bacteria. قاعد بدخل بكتيريا من حيط القلعة بدخلها جوا على الثرون روم أبدا عند الملك اللي هو مثلا بالبلد أو بالبون وبتسكر عليها بعدين فبتصير الأمور anybody can be introduced with human manipulation. Trauma is a similar case but التروما ما بصير جوا المستشفى مثلا هون ما بنحكي عن surgery ممكن يصير مكان ثاني so a different spectrum here is also seen. Significant tissue damage تمام حكينا significant tissue damage destruction devitalization هذا حكينا. Not necessary to have an open wound or a compound fracture. In similar fashion what is seen in pyomyositis is damaged tissue and internal bleeding slows down the circulation which creates favorable condition for bacterial growth. كله حكينا. Okay, so in these damaged tissues, when damaged tissues does occur, a bacteria from the peripheral veins or lymphatic channels, which that is low enough, can be sufficient. لأنه هنا صار في عندي damaged tissue. if you happen to have low level bacteremia, إذا ما كان في damaged tissues, these bacteria will probably more likely to just keep passing through. الشارع ما له شيء فبضلها ماشي بالشارع وبتروح بسلام. بس إذا الشارع خربان صار في damage. إذا كان في low level bacteremia, more likely إنه هاي البكتيريا will not be able to go to the other side and will sit there. If it happens to be an area with مثلا bone or muscle or whatever, this low level bacteremia, which otherwise may not have caused an infection, would cause an infection because of the damaged tissue. Okay, bacteremia is a frequent cause of osteomyelitis, maybe arising from endocarditis or seeding infection مثلا from abscesses or boils. A prosthetic joint and staph aureus study shows that staph aureus bacteremia causes a rate of metastatic osteomyelitis approaching about 28% if there is a prosthetic joint in place. هذا ترجع لنفس النقطة اللي حكيناها هون. Now this is the presence of prosthetic joint most likely would have introduced tissue damage لأنك قاعد تحط prosthesis. So then you're going through the skin اللي محل موجودة staph aureus. So may include low level bacteremia and then can introduce staph aureus back into the wound through مثلا contiguously or through the bacteremia here. It can be complicated by the involvement of methicillin MRSA. طبعا راح تكون مشكلة هنا وراح قاعدة بتزيد أكثر من sensitive strains. Urinary tract circulation. The overlapping circulation of the urinary tract and the spine is suggested. ليش؟ بيحكي لك especially due to the UTI causing pathogens. There is a circulation between the urinary tract and the spine, and this overlapping circulation can introduce urinary tract infection causing pathogens into the spine. عشان هيك بلاقوا when you see osteomyelitis in the bone surrounding the sacral spine and the lower lumbar spine, a lot of them has been shown to be caused by organisms that originate from the urinary tract. Limited vascular supplies, other predisposing factors, limited arterial and venous supply, which limits perfusion to the bone to the point that of inadequate response and poor healing. Obviously, تمام. Diabetes حكيناها, impaired immunity, hyperglycemia, loss of sensation, vascular disease, renal failure, كل هذا حكيناه. Diabetic foot, which also be true here. Epidemiology, تمام. In the US, acute osteomyelitis about 0.1 to 1.8% of otherwise healthy adult population. After a foot puncture, about 30 to 40% of adults with diabetes develop osteomyelitis. So it is quite common with diabetic foot. MRSA replacing MSSA, morbidity and economic burden is very greater for MRSA obviously. Is MRSA more aggressive؟ هاي حكيناها المرة الماضية أو المرة اللي قبليها إنه it's more likely to get more virulence factors and survive longer and become more aggressive because it has obviously acquired genes, virulence genes غير عن resistance, antibiotic resistance genes. Certain countries that have more aging population and or population with diabetes and obesity كل ما يكبر بالعمر بدهم راح يصير عندهم اوستيومايلايتس اكثر لانه راح يصير عندهم دايابيتس اكثر وراح يصير بدهم راح يصير عندهم اوستيوارثرايتس وراح بحاجه انهم ياخذوا بروستيسز. فكل هذا بضيف وعدد الحول حكيناها اللي هو عدد زياده الاطباء والصار في more better medicine and then more instrumentation and whatever. Any type of inflammation may lead to infection in a small proportion of cases. Richer countries have more orthopedics related osteomyelitis and poorer countries have more TB or brucella or significant wounds in society مثلا wars and accidents. Pathogenesis يعني هاي المحاضرة كثير بحبها لأنه بتلخص لنا يعني زي الدايابيتك فوت بتلخص لنا أشياء كثير and this is very true here as well. It can be applied to all pathogens that we mentioned so far. The most common predisposing factor of osteomyelitis is an area of bone that is defective in its viability and blood supply and sensation. This damaged tissue then suffers from reduced oxygenation blood supply which hinders the venous and lymphatic flow. فصار عندي أنا less in and less out, so less blood in, less blood out. These are prime factors that provide bacterial optimal growth, مثلا oxygen, nutrients, less inflammatory cytokines and white blood cells. As we mentioned, host factors such as poor nutrition and immunosuppression will also be relevant عفوا. Diabetes كمان حكيناه وما في تشديد هون. Diabetic neuropathy makes progression of the disease much worse, obviously, because the patient more likely to be unaware. Diabetes is a significant cause for many amputations due to osteomyelitis. So more likely to have an amputation if you have diabetes in a patient with osteomyelitis. This will probably be true for immunosuppression. Bacterial pathogenesis. Bacterial pathogens that cause osteomyelitis perpetuate themselves. They maintain their presence. How? They do this by secreting toxins that continuously damages the surrounding tissue. So Staph aureus is especially strong in this respect, where it keeps colonizing the nasal area and out about 1/3 of healthy people, and can produce different cytokines and enzymes that destroy tissues and affect neutrophil response. This is important. So certain strains of Staph aureus can survive the uptake into phagocytic vacuoles in the macrophages. هذا بخليهم enables them to keep causing tissue damage by consistently evading the host defense. So basically, you have two populations of Staph aureus. You have intracellular and extracellular population in an area where it's already has very little entry of white blood cells. Some of them are hiding in whatever blood cells that come inside. Some of them hide inside these blood cells and they maintain themselves there. And some of them are المقاتلين المحاربين that are extracellular and they keep causing damage. So whenever المقاتلين بيصغروا بقل عددهم, the intracellular population will replenish the extracellular pathogen and this will keep going on and on and on. This is not true only for bone. This happens in the urinary tract. This happens anywhere where there is biofilm formation or ability of cells that have part of its life cycle to become intracellular. Any bacteria that has an ability to evade the immune system, evade destruction inside the vacuoles, inside the phagocytes, will have this kind of population. So can you ever reach sterility? No. Sterility and healthiness can only be achieved with a proper immune system. The only reason why إحنا ربنا خلقنا بهاي الطريقة The only reason why you are healthy is because of your immune system. As the immune system wanes, كل البكتيريا بتكشر عن أنيابها. They show their potential because they were stopped by the immune system. فإذا بتطلع عليها مثلا في إلها كمان يعني منظور زي ما بشوفه بالبشر مثلا بالحروب وبالدول وبالتاريخ. مثلا as one area there is an empire ما حدا بيقدر يقرب عليها. لما يحسوا فيها ضعف بلشوا الأعداء يحاولوا يدخلوا مثلا خلال المدن، يشوفوا شو بيقدروا ياخذوا. إذا طلعت مش ضعيفة عن جد it will repel them. إذا طلعت عن جد ضعيفة it will overcome them. It is the same for your body. So كل هدول أعدائك and your soldiers, your immune system is what keeps these in check. So Staph aureus has the capacity to remain dormant. هذول بسموهم non-culturable but viable forms. تشبه مش seed. It's not a spore. يعني ما لها keratin layer وما لها مثلا germination, but it is dormant enough. It turns off all its genes وبضلها قاعد in a way that if you try to culture it does not grow. Why? Because it has turned off all its genes. ما فيها respiration, ما فيها production of proteins. So if you put antibiotics on them, you might even not kill it because it's not using anything. It's not making cell wall. It's not making proteins. It's not making DNA. It's قاعدة ولا بتعمل طاقة ولا شيء. These are called dormant forms of bacteria. Almost all bacteria have these dormant forms. These are resistant forms that may hibernate and remain inactive for decades before infection can erupt at the site of old injuries. Especially penetrating wounds, shrapnel اللي هو لما مثلا قذيفة تنفجر أو هذا بيطلع منها مثلا شظايا. هو shrapnel هو شظايا. Although coagulase negative staph are typically less virulent than Staph aureus, but they have been found to persist and producing a biofilm حكينا هاي allows them to persist for many years, especially prosthetic joints. وحكينا حلها الوحيد انه to remove the prosthetic joint وانت بتصير الدكتور اللي عمل لي عملية مرتين وما بيعرف يشتغل وهالحكي كله. Coagulase negative staph is not uncommon for prosthetic joints to show no symptoms and suddenly show infection a year or even more later, as we mentioned. How much other organisms use their biofilm to their advantage is not fully understood, but biofilm production probably plays an important role in osteomyelitis, especially in chronic forms, and this can be applied to the resistant forms, it can be applied to the dormant forms, it can be applied to less penetration for antibiotics. كل الأشياء هون بتنحكى. Multiple bacteria may be recovered from cultures, especially when there is an entry wound. This makes the decision which one to target in antibiotic therapy difficult. Sometimes you might want to wait because bacteria can compete with themselves. So if they find an area where they want to start causing destruction, you might, with your initial antibiotic therapy, you might make it worse, you might make it better. Because also bacteria, as they are growing, they will fight to see who will become dominant. Sometimes they're synergistic if there is facultative anaerobes to make a place for anaerobes, because anaerobes will not take any oxygen from the facultative anaerobes. فبنخليهم عايشين، خليكم ما عندنا مشكلة. At this point, typically common skin flora and colonizing bacteria are not targeted. If they are, it might make them more aggressive and resistant. This is what I just mentioned. So you may not want to target the skin flora because you don't want to make them more aggressive and resistant. Anaerobic bacteria can often be recovered and can play a synergistic role with other pathogens, as we mentioned. And this is you may want to, in your treatment, choose an antibiotic that may also cover anaerobes. Clinical features: acute osteomyelitis presentation usually in pediatric patients and due to hematogenous spread, whereas هذا الأكيوت. Subacute to chronic forms are usually in adults. So acute osteomyelitis usually in pediatric patients لأنه more likely to have hematogenous spread. Subacute chronic forms are more likely to be in adults. Why? An adult is more likely to have a more competent immune system. Onset of pain around the affected site, and then local and systemic signs of inflammation, as we mentioned, swelling, tenderness, warm erythema may or may not be present. Why? Because this is a deep infection, especially in the vertebra, hip, or pelvis, and all of these are not long bones. Chronic osteomyelitis may begin with local signs of inflammation and then present as a sinus tract, as we mentioned, إنه بيطلع sinus أو بيطلع منها fluid, probably pus. may even fracture. ما صار معه شيء، صار معه fracture. صورت له بعد ما صورت الفراكتشر لقيت انه في ضعف بالبون هذا، عشان هيك صار في fracture. الضعف هذا probably an involucrum or sequestra or something that has changed the shape of the bone, made it weaker. It's not as strong, and that's why it fractured. If skin ulcers are present that are prolonged, that fail to heal with antibiotic therapy, it may indicate an underlying osteomyelitis. So إذا واحد عنده skin ulcer مش قادر تشوف، maybe زي ما حكينا it may have underlying bacteria that keeps replenishing this ulcer. If bone is felt when palpating an ulcer can be sufficient to diagnose osteomyelitis. تحس بالبون وانت عندك ulcer، بتحكي بجوز هذا البون قريب كتير على الulcer، that can maybe this is the seed area or the area where all the bacteria is coming from. Diagnosis. So this is usually based on clinical suspicion and then confirmed by radiology, microbiology, and then pathology. Blood tests may be raised but maybe you're normal، فالوايت blood cells may يكونوا عاديين. Inflammatory markers عادة بتستخدم CRP و ESR, usually high. الحمد لله إنهم are usually high. CRP changes occur earlier in bacterial infection. However, ESR and CRP are not specific and can be elevated in other conditions other than osteomyelitis. بنعرف الحكي إنه they are in all inflammation will elevate these markers, and we don't يعني it's not specific to osteomyelitis. Blood cultures are more likely positive in vertebral infections and in hematogenous spread. So those that have contiguous spread are less likely to have positive blood cultures. Radiology, plain X-ray may show changes about close to 2 weeks after infection, and this may eliminate the need for further studies. Bone loss, periosteal elevation, swelling, break, sequestra, كل هالحكي may be seen, and shadow around the foreign bodies are marks of infection. CT or MRI are investigation of choice. MRI is both specific and sensitive, and may be contraindicated in patients that have metal wear, as بس may cause an artifact on CT. So here هذه ما بدها يعني تجيب طالب صف ثالث تحكي له شو الغلط هون، بحكي لك فيه هون إشي مش مزبوط. So as you can see, this is probably a sign of osteomyelitis. It's breaking through. Probably this is has caused a fracture or an old fracture is in its healing. So this is quite a good picture. هون أشياء شوف مثلا elevation بالبيروستيوم. Yeah, I think that's probably that's it. The soft tissue here, maybe there's a bit of swelling here, maybe not. More here. This is probably an abscess here as well as here. يعني imaging I think it's easy enough. Biopsy. An open or percutaneous bone biopsy should be taken and sent to microbiology and histology. A needle aspiration of the pus is both diagnostic and helps in treatment. And why? Because you are taking the pus out, and that is self incision. زي كأنك تعمل incision and drainage, because you're not gonna just take it. مش راح تأخذ بس نقطة pus بتوديها تترك الباقي. If you aspirate pus, you aspirate all of it. Aspirate as much as you can. Take it all. فهنا هو until you drained it. Biopsy can be taken in open surgery with debridement of all the necrotic tissue. Antibiotics should be stopped about 2 or 3 days prior to the biopsy. Why? Because you may change the makeup of the bacteria, and then you want to improve the yield of the culture عشان تعرف exactly what are you dealing with. PCR and sequencing technology are becoming more standard diagnosis to detect and identify specific organisms. Even their sensitivity to antibiotics within hours instead of days. يعني if you do a PCR عادة PCR بأطول حالاته بيأخذ 3-4 ساعات. So you can do multiple PCRs and then you can have your answer within hours. The problem is that with PCR you have to ask the question, a specific question each time. يعني ما تقدر تحكي إنه which bacteria is this وطلع لي يا PCR because you're targeting specific genes. فبدك تشوف مثلا is this فسؤالك is yes or no, is this staph, yes, is this no مثلا, is this strep, is this that, is this that. بعدين بدك تسأل سؤال does it have this protein, does it have that protein. So this makes PCR more you're asking many questions. بالculture انت بتحط الكلتشر هي بيطلع لك الانسر انه this was سؤالك راح يكون what is this وبيطلع لك مثلا بعد فتره انه الكلتشر طلع مثلا staph. So you're not asking is this staph, it's not a yes or no as a diagnostic tool. فthis يعني فهنا clinical data can help you direct your questions queries عشان تعرف which PCR you want to run. Management, general principles, the aim of treatment is to eradicate the causative agent and restore function of the bone. That's what you want to do. You want to reduce, and optimally, you would like the causative agent to come back to the same levels that it had before the infection. So, which is usually probably 0, and then you want the function of the bone to come back to the pre-infection. This is the optimal goal. Obviously, you want to get as close as possible to these two goals. In adults, usually treatment with combination of surgical debridement with antibiotic therapy. Surgery. The principles of surgical therapy here is removal of the infected and metalware, and then removing manage the dead space to close up the dead space, closure, stabilization of the infected fracture. Antimicrobial therapy. Choice of antibiotic therapy here is based on the culture and sensitivity results. Why do we always have to have it? Because the duration here, we always have to have culture and sensitivity because you are using antibiotics so a little bit blindly because you don't know what organism that you are using, and you are using it for a prolonged time. You're using it for about 4 to 6 weeks. And some guidelines بيحكي لك 4 to 6 weeks of IV therapy. يعني بده يقعد لك المريض 6 أسابيع من المستشفى. طبعا يعني that's difficult. So the addition of rifampicin to beta-lactams was shown to be effective in certain staphylococcal osteomyelitis in certain animal models. Particularly those that have prosthetic material, which is a good sign. Patients are usually discharged once they are clinically stable, and then treated outpatient with an IV antimicrobial catheter. تخليه عنده catheter وبيضل يرجع على المستشفى بياخذ الجرعة وبروح. طبعا هذا شو المشكلة؟ أي شيء بالحياة بدك فيها حركات كتير compliance بقل. وهذا إشي مثلا صعب على المريض. This is one of the challenges of treatment of osteomyelitis. حكينا عن hyperbaric oxygen has been shown to be effective in this case with animal studies. Let's see how good it will be with in humans, as it can be as adjunctive therapy. هون ممكن أحسن لأنه مش زي الألسر إنه مثلا you want it to heal within days. This is something that takes weeks. So maybe. Negative pressure wound therapy. So you are changing the circulation إنه بدل ما كل شيء يضل يتحرك لجوا على الwound مثلا عنده osteomyelitis. You change the pressure so that you're trying to change the direction of fluid from the osteomyelitis out. So this is called negative pressure wound therapy. Vacuum assisted closure. تسكره بحيث إنه يصير الفاكيوم يضل يطلع الأمور لبرا. So this is being increasingly used and may accelerate wound healing in complex wounds and in diabetic patients as well. التيبل الكبيرة تبعت الانتيبيوتكس for treatment of osteomyelitis. So methicillin susceptible strains, anti-staph medication. ما طلع علينا كبيرة وتخوف. Everything we said we mentioned. There's nothing here new. So sensitive strains, anti-staph medication. سيفازولين زي ما حكيناهم يعني nothing new. But the problem here طلع إنه Q6 hours, so you're giving 2 grams IV every 6 hours. So maybe more active than cephalosporins, but more difficult لأنه every 6 hours. But cefazolin 3 مرات باليوم, ceftriaxone مرة واحدة باليوم. So this is advantageous with outpatient treatment. Clindamycin had well studies for osteomyelitis, and then clindamycin is very notoriously سهل إنه نعمل له resistance. Resistant strain شو بدك تستخدمه؟ vancomycin, daptomycin, linezolid. Nothing that we did not mention. So كلهم مرة أو مرتين باليوم. Here MIC minimum inhibitory concentration is the minimum concentration that you require to inhibit the growth is more than 2 micrograms per ml. Here as the minimum inhibitory concentration كل ما زاد يعني كل ما معناته the minimum concentration of antimicrobial that you require to inhibit the growth كل ما زاد معناته this bacteria is more resistant. فالstrains that have an MIC of more than 2 micrograms per liter may not respond well to vancomycin. So هذول بكون يعني بسموهم فيزا vancomycin intermediate strains. بالزيادة إنه إحنا قاعدين نحكي عن osteomyelitis فإنه penetration ما راح يكون very good. Daptomycin has a promising profile, but has adverse effects because of the prolonged therapy. Linezolid has effectiveness, but again unknown adverse effects وكتير عالية with prolonged therapy as well. And it's only bacteriostatic, it's not bactericidal. Streptococci, penicillin. هذا حكيناه من penicillin. تذكروا من table الantibiotics. So penicillin here can be used every 6 hours. Not all streptococci are susceptible. فممكن نعطي ceftriaxone alone, and that's it. Enterococci, the antibiotic resistant streptococci اللي شو بعطيهم أنا penicillin plus gentamicin plus maybe even vancomycin. So Enterobacteriaceae again ceftriaxone, ciprofloxacin. Ciprofloxacin has an excellent penetration to many tissues منها البون. Pseudomonas ciprofloxacin as well. Okay, there's still controversy about the optimal route and duration. إذا هذا الحكي اللي بعطيت فيها هذا, this is one of the foremost books بالinfectious disease. حتى هذول لما تحكي له بعض الأطباء زملائنا بحكي لك مثلا no this doesn't work, this doesn't work, I have to use this, we use this, my experience is different لأنه osteomyelitis is such a difficult syndrome. There's still a controversy about the optimal route and duration of therapy. 46 weeks course of IV therapy remains the standard. Although in pediatric population some studies are showing shorter duration with oral therapy may be adequate. Because some of the active agents reach comparable levels when given by mouth, a switch from IV to oral may be appropriate. Duration is increased for more extensive disease and reduced for less, and then patients with additional comorbidity طبعا بدك تعطيه أكتر وأكتر. شو بصير عندي complications for osteomyelitis? Sinus tract formation حكيناها, pathological fractures حكيناها, hematogenous spread and sepsis again we mentioned that. Tumors in patients with long-standing هذا بجوز حكى لكم عنها دكتور موسى. So long-standing osteomyelitis أي شيء بالجسم as you have seen in pathology, anything anywhere in the body where you have chronic inflammation over and over and over, healing over and over and over, a lot of cells are being replaced, so a lot of DNA is being produced, a lot of DNA is being copied, so there is more likely to have errors and more likely to incur mutations and then may cause cancer. هون tumors in patients. فاللي بدخن شو بيسوي قاعد every time كل ما بشرب سيجارة قاعد بقتل كل الابثيليال cells. بعدين بدهم يعني بترك الدخان ساعة بلش الابثيليال cells يرجعوا and then they are dividing again and again بروح بدخن كمان سيجارة وهكذا وهكذا they're asking for it. So مثلا sometimes you don't know what you're doing. Some people مثلا work with certain مثلا بالدباغة, so they have certain chemicals that enter their body and then is filters into their bladder مثلا. So over time it keeps destroying this transitional cells, and then this transitional cells بضلهم بيطلعوا بروحوا بيطلعوا بروحوا بيطلعوا بروحوا, and this predisposed to cancer. Again مثلا acidity، واحد عنده acidity بالstomach and then you have metaplasia and then الخلايا لأنه because you have changed the usual environment لها مثلا وهكذا. So this is also true for osteomyelitis. So what do you have common thing? Osteomyelitis, squamous cell carcinoma is the most common malignancy that may arise in the setting of osteomyelitis. Prognosis varies. Vertebral immunocompromised is probably the worst. Mandible following tooth extraction, early proper treatment probably has a better prognosis. Prevention. What prevention do you need to have? Osteomyelitis can be prevented with better pre-operative infection and preventive measures, as we mentioned. So you have to be very clean with your surgery. That's basically the aseptic technique at all levels. حكينا ميبرسين chlorhexidine to remove the colonization of bacteria. Early diagnosis and treatment. Early surgical treatment of wounds. Sacral ulcers can be often a point of infection. هدول الناس بيكونوا bedridden for a very long time. Can be easily overlooked. So pressure sores have to be taken care of as not to cause osteomyelitis in these patients.